I can say that because of the difficulty of the techniques that we can do and find the virus and try to correlate the viral infection to endodontic infection, therefore we don't have a lot of evidence about that. But one of the scientists in the world who actually spent a lot of time evaluating and investigating about the viral infection is Professor Mohammed Severity. And I am very honored, and I have actually this opportunity to introduce him to all of you, and you can see him actually, and he actually honorably accepted my invitation to join us today. So Dr. Severity received his Doctor of Dentistry degree, DDS degree from University of Texas, Dental Branch in Houston. He completed a program in periodontics at TUMS School of Dental Medicine, and he served at postgraduate Department of Periodontology at University of Texas Dental Branch at Houston. He completed a program in endodontics at Herman Ostrow School of Dentistry of University of South California. He has been a member of American Dental Education Association, and he passed actually ADE postdoctoral application support service in past 3 years. He currently serves as director of postgraduate endodontic and chair of PECC at University of California at San Francisco. He is board certified, American board certified in endodontics, and he has made many invited presentations and published along with several textbook chapters, and he already published a textbook as well. He has received a certificate in recognition of outstanding service as a faculty member to the enhancement of education and clinical excellence presence by the Advanced Endodontic Herman Ostrow School of Dentistry of University of Southern California, and certificate of appreciation for the service and significant contribution to Periodontal Division, University of Texas Dental Branch. He was honored by Hale T. DeBass Academy of Medical Educator at University of California, San Francisco, with an Excellence in Teaching Award. He is the current president of Northern California Academy of Endodontics as well. And this is an honor to have Professor Severity with us. So what we are going to do today, we are going actually to ask one of our colleagues, one of our young fellows, our endodontic postgraduate student, Dr. Kiafar. And Dr. Kiafar is going to present. Dr. Kiafar, please unshare at the moment. Let us start and then we go back to that. Dr. Kiafar is going actually to give us a presentation about the article first, and then I may interrupt and stop him and start asking some questions from Professor Severity. Professor Severity also may stop him and also ask questions or explain something if Professor Severity thinks this is necessary to do that. If any of you have any question, you may just raise your hand electronically, obviously. Samira, can you show that how to raise our hands? Can you raise your hand electronically and show to others, please? And then now you can see Samira raise her hand. So if Samira wants to ask any question, we can ask her to shout it. By the way, let me introduce Dr. Professor Samira Shahsia as well from Ahvaz University. She is also an endodontist, and we always have her as a very supportive member of this journal club and other journal clubs that we already have. Thank you very much, Samira. Okay. Before we start, I'm going to ask Professor Severity to have some word as the introduction, and then Dr. Kiafar is going to have his presentation. Professor Severity, thank you very much. I have enough word to say thank you. I know you are very busy And thank you very much for accepting our invitation. We are going actually to have two programs, one based on Western Zone, which is on Saturday this time in 6 weeks, sorry. And in 3 weeks, we are going to have other program for the Eastern time, which is actually on Fridays. Okay, Professor Severity, please.
Dr. Nikufar, my dear friend, thank you so much for your kind words. It's just really happy to see you. I haven't seen you a long time, face to face. I would like to just, say a little bit about the viruses in endo. When organ transplant started in medicine long time ago, they called the first surgeon a criminal. And of course, the society did not accept this work, and it took a long time, basically, which is we know right now, this is a lifesaver surgery, and everybody accept organ transplant. The idea of virus, of course, when we started in 2001 with our model, is still not fully accepted in endo. And if you look at at least few authors, which is when write about the microbiology, basically yes, they talk about it, but is not fully integrated as part of etiopathogenesis of endodontic abscesses. This piece of work, which took us about almost 4 years, is a clinical proof, which is, yes, the viruses are a main part of the acute apical abscess. And the story does not end here. And we should expand it to also to medical, because we all know that one of the reasons for failure of organ transplant is human cytomegalovirus. And where is the source of this human cytomegalovirus? Is oral cavity. And we have a say about this to our medical colleague. And hopefully, we start more research, more work on this area, and hopefully, be able to educate our medical doctor also. Listen, we are the one who we can control these viruses and prevent, or at least the patient who wants to go under any organ transplant should be seen by an endodontist. Or periodontist to say, because this is what it is. Anyway, I'm ready, Dr. Nikufar, and that was a brief say.
Very interesting introduction. Thank you very much, Professor Severity. Thank you very much. And I want to welcome all of our colleagues from around the world. Professor Talal Al-Nahlawi, I know he's very busy and he has very busy schedule, but he's also he already joined us. Thank you very much, Talal. And Talal is always very supportive for our society and for APEC as well. And thank you very much from all of you for joining us at this time. Okay, Maliheh, okay, Talal, do you want to have some word before we start officially, please? Go ahead.
Thank you. First of all, I would like to thank you, my friend, and really, it's a very nice topic. I'm looking forward for the nice discussion, and always I'm happy to be part of this very nice educating session. I wish you all the best for you and for the authors and for the presenter as well.
Thank you very much. And I'm sure Professor Severity is open to future collaboration, Talal. So I know you're a very good researcher, and I can see many of our other researchers as well here. So Professor Severity, as I have already have this honor actually to work with him and under his supervision. So I'm happy to say that he already told me about the future collaboration with all of you. So at the end, I will send his email to any of you if you have any suggestion or anything for the future work. I'm sure Professor Severity is happy to help. Okay, thank you very much. Maliheh, can we have one of the clips, and then we are going to start after that by presenting the article. Dr. Kiafar, please go ahead.
In the name of God, we are going to talk about this topic today, valacyclovir in pain management of acute apical abscesses, a randomized placebo-controlled double-blind pilot study. First, we have an introduction. The AAE defines the term acute apical abscess as an inflammatory sequence to pulpal infection and necrosis. And it's characterized by rapid onset, spontaneous pain, percussion sensitivity, pus formation, and swelling. This acute apical abscesses is related and probably caused by herpes viruses and gram-negative anaerobic bacteria. In a 2016 national surveys, 96% of endodontists prescribed bacterial antibiotics to treat and alleviate pain with acute apical abscesses. And in a study done by Whitmer et al., they identified bacterial DNA in even healthy pulpal tissues. For herpes virus endodontics, Dr. Severity et al. Added herpes viruses to the pathoetiology of preapical granulomas. They showed a strong statistical association between active human cytomegaloviruses and Epstein-Barr viruses in symptomatic preapical patosis. The co-infection of human cytomegaloviruses and Epstein-Barr viruses demonstrate a particularly high occurrence of lesions with symptoms, radiographic bone destruction, and major bacterial pathogens. And in another
Dr.
study,
Kiafar, can I stop you here? Dr. Kiafar, can you go back to the previous slide, please? Professor Severity, I know it is too early to start asking questions, but I have a question which I have received also this question from some of my colleagues, which is about the correlation and causation. We are very worried about the result of some of the studies that show that something may happen at the same time, and even they may statistically correlate to each other. But how we can prove that there is a causation between these two effects? For example, when you say Epstein-Barr virus may have some effect on the symptomatic preapical pathosis, the only evidence that we have is they happened at the same time, and we find them at the same time during a symptomatic preapical pathosis. Is it enough to show the pathogenesis and causation effect of Epstein-Barr virus and symptomatic preapical pathosis? And do we need something else as well? Can you explain that, please, for us?
Sure. That is, of course, a very, very good question and required a long answer.
I always ask questions. I always ask good questions.
Yeah, that is a very good question and also tough question. You know what? Let me just get back to you. One thing which is we did not basically did PCR to detect a virus, because that someone may say, oh, listen, yes, the virus you detected is there, but it's PCR. We don't know does anything, any metabolism or so. We used RT-PCR. That means we detected the virus while doing the protein synthesis. That means they are active there. They are not there. They are active there. That's the first thing. The second thing, if you look at also when the viruses are active, one of the studies we did, and we look at the cytokines, we see that when the viruses are active, we see a surge of IL-1, for example, TNF-alpha. We see a surge of other cytokines, which is when the virus is not active, is not there. This is another piece of evidence. And also, we look at the gram-negative and also gram-positive bacteria. When the virus is active, we can see also at the high level of the gram-negative bacteria and gram-positive bacteria, which is all indicate that when the virus is active, we see that surge. But when they are not active, we don't see that surge. And of course, the last paper is clinical evidence, which is, since the virus is there, therefore antiviral works. However, we should remember that this is a vicious cycle. You all know that virus does not metabolize unless to be inside another cells, right? Therefore, the HCMV basically go to T cells and macrophages and monocyte. B cells go to different type of cells. Therefore, when there is a infection at the pre-apical area, we all know that there are the innate immunity, there is macrophages, there is other cells. Therefore, the viruses use that cell, T cells, B cells, and go there to the pre-apical area. And then if you look at the pathogenesis of these viruses, for example, when the HCMV is active, right, there is a basically upregulation of IL-1 and TNF alpha. And as a result of this upregulation, then upregulation of matrix metalloproteinase, which is cause destruction, and then also a surge of the prostaglandin E2. There is a cascade going on by activation of these viruses, and then cause a localized immune deficiency. And this result what? In surge of the cytokines and bacteria. I don't believe that the bacteria by itself can cause that type of pain and swelling. They're not capable. Therefore, if we look at the whole picture, we see that they are not there by standard. We just detect them. They are there, and they are basically one of the main reasons for this clinical sign and symptom of the acute apical abscesses.
Great, thank you very much. Dr. Hadi Asadian has a question. Please go ahead. Hadi.
Hello. Hello. Is my voice clear?
Yes, yes, yes.
Hello. Thank you very much, Dr. Nakufar, for holding this nice conference, and I'm really happy to see Professor Severity from far away. Of course, I had the honor to host Professor Severity in Shahid University, I think about 2 years ago, and now I'm happy to see him online now. There is a point about the causal relationship that I would like to put more emphasis on, and that is the temporality. Of course, when you consider two major things to have a causal relationship, there is also a very important issue to consider, and that is temporality. It means that if you believe that A causes B, A should happen before B. If the factor A is the cause and B is the effect, A should precede B. But sometimes in medical status, you can have this conflict that A and B happen together, and you're not capable of distinguishing which one can precede the other. For example, we can have this conflict in peptic ulcer and Helicobacter pylori. There is still the controversial issue that it's not clear whether Helicobacter pylori is the causative agent of peptic ulcer, or it happens as a result of peptic ulcer, and because of the necrotic area that is created by the peptic ulcer. Of course, this is very difficult to establish, and it needs very, very high level evidence, and it needs a great deal of data, especially in a pathophysiological point of view. I would like to ask Professor Severity to inform us more about the detailed studies and investigations that has been performed in this regard to establish this causal relationship.
I think Professor Severity already mentioned something about the cascade of the interleukins and also about the real PCR. I think the most important one is real PCR. But Professor Severity, do you want to add anything else?
You know what, and thank you, Dr. Asadian, and you're right about it. You know what, as I said, as Dr. Nikufar asked me, you're right. But you should keep in mind this fact that, which is viruses cannot go to a periapical area unless the bacteria be there, because as soon as any, for example, LPS or any type of gram-negative or whatever bacteria gets there, there is an activation of immune system, right? And then we need the cells, we need the immune system cell in order to virus go there, because virus by itself cannot metabolize anywhere. They have to get inside the cell. But when it get inside the cells, that's all the cascade happen. And then the importance of this, the last paper, is shows that clinically, that's true, because antiviral work. When we give the patient antiviral, with the first night, all the pain and most of swelling is gone compared to antibiotic.
No,
because
I'm sorry. My question is that how do you know that the viral infection is not the consequence of a bacterial infection? How do you know that viral infection is not a cascade? I mean, it's not the effect. How do you know that it's the cause?
Because well, as I said, of course, it's not the consequence, because if be the consequence and if be something to be there, then you don't see any surge of the cytokines. You don't see any local immunodeficiency because the bacteria is there. I'm asking you, Dr. Asadian, why on a stable lesion become stable? If the cause is bacteria, the bacteria is there. Why then is nothing happening? You see a patient for years, and then if you remove the tooth with radiolucency, you see the bacteria inside the tooth. Then why is there? Why so stable suddenly become unstable? If the cause, the same question which you're asking me, I'm asking you about the bacteria. Why?
Yeah.
Okay.
Yeah, of course.
Yeah, thank you very much. Thank you very much. And Professor Nair Abul Saad from Lebanon. Professor Nair is a periodontist, and also he is also a specialist in oral medicine. Professor Nair, please go ahead.
Good evening, everybody. It is nice to share this very interesting meeting. It is the second time that I participate in this.
Thanks for joining us, Professor Nair.
Thank you very much.
And you know, Professor Severity is also a periodontist, so you have some mutual things that we don't have it.
I just have a quick question. Will the local antiviral treatment may also work instead of systemic administration, and the possible side effect?
You know, thank you so much. Yeah, it may, but of course we need to do a research to really find out whether it works or not. Dr. Nikufar, do you have me?
Yes, please,
okay.
Please. We can hear you very well. Please.
Yeah, I think that's one topic which we should do some sort of investigation and then see whether it works or not. I don't have the answer for you because we have not done it. But if we can do it, absolutely, I can go further, Doc. And then we can also, I advocate the vaccine for the prevention of acute apical abscess. This is another thing where we're just thinking about it. Yes, it's all possibilities. Yes, since we know that they are there, we know that they're, yeah.
Professor Sabdi, I think Professor Nair is worried about the side effect of the systemic administration of antiviral medication.
But you know what, Dr. Nikufar, yes, but you know that antiviral is safer than antibiotic, okay? Because they don't change the flora in the gut and cause other issues. Antiviral is very safe. The only thing is, of course, have some effect on the kidney and liver, which is, if the patient has kidney issue and liver, then should be consulted with physician. The same thing for antibiotic. But I think antibiotic has more side effect than antiviral.
Okay, thank you very much. Dr. Kiafar, please carry on. Share it again and carry on. We have another question that we come back to that from Professor Fatima Betul Bashturk from Istanbul. We come back to you, Fatima.
May I start?
Yes, please.
Another study done by Jackowicz et al. They found that Epstein-Barr virus positive lesions exhibited high levels of expression of rank ligand and osteoprotectin, and an imbalance in the rank ligand osteoprotectin ratio, which caused compromising the osteoimmunology of preapical bone. Now we want to discuss where this idea came from. HCMV and EBV, together with specific bacterial pathogens, are also involved in the development of advanced marginal periodontitis. And this concept led to a study done by Sunday et al. They had a patient with recurrent refractory periodontitis, which was EBV positive, and they prescribed valacyclovir for 10 days to this patient as sole treatment. And after a 1-year follow-up, they observed an absence of periodontal EBV and dramatically improved periodontal health status. So they decided to conduct this section. And why we choose
Professor, do you want to
valacyclovir?
add anything about this case report here?
You know, Sunday did a great study, a clinical study, and when he used the antiviral medication, and he saw a better attachment gain and less pocket depth. And yes, this is a great study. He did a great study. Yeah.
And is it the level of this study is just case report? Do you think is it enough to show that such a
No,
thing to us?
Dr. Nikufar, you're 100% right. It's not enough. Of course, you know, I encourage you know, periodontist colleague to do a sort of like randomized clinical trial. This is a case report. I agree with you. Just case report is not enough, and it may not be a good evidence because maybe by chance. I agree with you. Yeah.
Okay, thank you very much. Dr. Kiefer, carry on.
Now we want to talk about why we choose valacyclovir over acyclovir, because they have the same effect. They both inhibit herpes virus DNA polymerase, and they are effective against active herpes viruses. Valacyclovir has a greater oral bioavailability than acyclovir. It's fast acting and it's effective against Epstein-Barr virus, herpes simplex virus, and varicella zoster virus in active phases. And these viruses, as we mentioned before, they are in active acute apical abscesses and extensive preapical lesions. So we can use this medicine for this research. And for safety of the drug, an immunocompetent patient can tolerate prolonged treatment with valacyclovir, dosage of 500 to 1,000 milligrams per day, and the adverse events are infrequent and generally mild headaches. And for more information about bioavailability, we have a diagram here. When you take medicine orally, it starts to absorb, and the level of the drug in the blood increases and then decreases because of exertion. The area under this curvature, which abbreviated by AUC, shows the total exposures of the body to active ingredients of the medicine. So valacyclovir has 3 to 5-fold greater oral bioavailability. For example, valacyclovir AUC at dosage of 250 milligrams 4 times a day is equivalent to 800 milligrams acyclovir 5 times daily. So it's much more better than it. But when I was searching for this one, I found something more. When valacyclovir undergoes rapid and extensive first pass intestinal and hepatic hydrolysis, it have 2 metabolites, acyclovir and L-valine. Because this is the structure of valacyclovir, this is an amino acid called valine and acyclovir. And I searched a little more about it. I found that L-valine or valine is a branch chain essential amino acid, which is abbreviated by BCAA. And this amino acid, based on the this study, has anti-inflammatory and anti-genotoxic effect. As it is mentioned in the conclusion of the study, this BCAA significantly reduced the level of pro-inflammatory cytokines and can be utilized as anti-inflammatory agent. And this fact has two sides. One side is that it's good for a patient because by one medication, it can have two effects. One for antiviral and one for anti-inflammation. And it has a bad effect for our study because it can be conflicting factors. And then considering the predominance of HCMV and EBV in active infections in acute preapical lesions, we can, okay, can I go on?
Yes,
we
please.
can propose adjunctive valacyclovir treatment to reduce the pain and the need for analgesics. For materials and method, first we explain the inclusion and exclusion criteria.
Dr. Kiafar, can I stop you before you go to methodology? Is there any question, any comment so far? Because now we cover a very important introduction by asking Professor Severity to tell us something about why he decided to do this study. And there are two questions. Professor Fatima Batu from Istanbul and Professor Shasia from Abbas. Fatima, please go ahead.
Actually,
Dr. Kiafar,
can
you? Yes, please. Thank you. Good.
Okay.
Hi, Fatima. Please go ahead.
Hi, Doc. That's a really nice topic, by the way. I really enjoyed every second of it because I'm an active clinician, and what I come across with is that, for example, for 9 months, I treat patients in the same manner and nothing goes wrong. But in the 10th month, one patient and another, a lot of flare-ups. And I sense that there should be something more than bacteria because I kind of sense that it's kind of a viral infection because it just happens for a specific period of time and lots of flare-ups come up to the clinic. And actually, we did a study in 2015. We put calcium hydroxide for large periapical lesions and then did some PCR tests. And what we came across was that there was no difference if we put calcium hydroxide or not in preventing the viruses that are present in the periapical lesion. So that was ineffective after all. So what I was wondering is that, can we prescribe them? I mean, can we prescribe these medicines for the patients?
Absolutely, you can. And we do in US, we're encouraged to do because you help patient. Yes.
Okay, that's very clear, Fatima, I think. Very clear, very straightforward answer.
Yes, thank you.
Because it is based on a lot of evidence. Dr. Severity already worked on that in more than, I think, 20 years, I believe.
That's true, Doctor.
Okay. Dr. Shasia, please go ahead. Yeah, please, Dr. Severity.
No, that was a great case. I mean, which is she had in Istanbul. I think she's right. You know, she basically clinically sensed that, and you know, we basically lots of time don't realize it, but this is like herpes virus, for example. You know, none of us, we are all sitting next to each other and we are fine, and no one. But tomorrow I wake up, I have something here. Oh, you're something here. What is this? Oh, you know, I had this. But this is the virus. But the virus has been in you. You always have had that virus. But something happened which you have it. You see it right now. You recognize it. But do you think you don't have? Yeah, you already have it. But it's right now activated. And then you say, okay, I have to take the antiviral. The same thing for, you know, for acute apical abscess. Anyways, let's continue this. Sorry.
That's great. Thank you very much. Samira, please.
Hello again, and thank you again for this friendly discussion. I didn't hear that if Dr. Kiafar indicate this question or not. I wanted to ask about the agent that this drug have, the BCAA. He said that it has some anti-inflammatory effect. I just wanted to say that does this make any bias in our study? Because we are bolding the antiviral effects of this drug to control the pain and the inflammation. I just wanted to see, okay, if BCAA is the causative effect of lowering this pain. So this is a great bias in our study. We cannot conclude that this antiviral agent is the drug that is the hero of controlling the pain. I just wanted to see and find out and listen the dear Professor Severity answer to my question.
Professor Severity, I think this question is also received to me from the notes that my colleague sent it to me. The question tried to emphasize that if the medication, valacyclovir, has some effect on the pain rather than just on the virus, then it may have a direct effect on the result. So that is the question, because in this study, you evaluated the effect of this antiviral medication on the pain rather than on the antiviral infection. And you try to indirectly show that, so there must be a viral infection that it controls that one. But something like metronidazole as well, about metronidazole, we know that it has somehow as just we can use it in infection because it has some effect on the pain as well. What do you think about that?
Okay,
thank you very much, Samir.
No, that's a great question. Dr. Nakufar, you know what? First of all, have you heard anyone prescribe antiviral for inflammation? I haven't heard. You know, as you go to a physician, oh, yeah, no, if it has, it's very minimal, okay? Because if that drug is not for inflammation, I think that's to me, it's just bad thinking. Sorry to say that, but and then if that's the effect of anti-inflammatory, then give the patient ibuprofen and the patient should be fine. We gave when the patient has acute apical abscess, you give patient ibuprofen. Yes, after a few hours, the pain comes back. But in our case, it was not the case. When the patient took antiviral agent, then the day after, the patient does not have pain or very, very minimal pain. If the effect of anti-inflammatory, then should the ibuprofen do a better job than antiviral?
Yep.
And also swelling. The swelling reduced dramatically. Yeah.
Okay, so you think even if it has some effect on the pain, still it is very, very minimum and it may not have any bias effect.
Absolutely. I don't think anyone has suggested that antiviral Valtrex is good medication for inflammation. I've not seen it, even in the medical literature. Yeah, you may,
okay.
Everything else may have, something, even ibuprofen or anything else, but this not is anti-inflammatory drug. Yeah.
Okay, Samira, are you convinced? Okay, thank you very much. Malihe, please.
Thank you.
Dr. Kiefer, please. So we are going now to discuss methodology of this study.
For methodology, first we talk about inclusion and exclusion criteria. The inclusion criteria, first is patient must be more than 18 years old. It must be systematically healthy, ASA class 1 or 2. Patient might exhibit clinical evidence of pulpal necrosis and acute apical abscesses. The patient must present with a radiographic sign of apical disease either by preapical radiology or a CBCT. Patient consented to receive conventional pulp debridement, incision and drainage at the end of the study, and persistent pain of moderate or higher level was the main inclusion criteria. The pain level was as follows: 0 mean no pain, 1 to 3 as mild pain, 4 to 6 as moderate pain, and 7 to 10 as severe pain. For exclusion criteria, smokers more than 10 cigars per day, internal or external resorption, marginal periodontitis, pregnant or nursing mothers, because hormonal factors may influence the preapical conditions, documented allergy or adverse reaction to amoxicillin or valacyclovir, amoxicillin because we prescribe amoxicillin to placebo groups, and the teeth with unusual anatomy or inaccurate clinical diagnosis on the day of treatment, which means if we have a participant at the end of the study, when we are doing the root canal therapy, we find out that it wasn't completely necrotic, it was partial necrotic, so we exclude this patient. And a patient must not take any antibiotics or antiviral medications currently.
Okay, Dr. Asadian has a question. Dr. Asadian, please.
Excuse me. To the best of my little knowledge, I have seen in methodological books that studies that are called placebo-controlled usually compare an intervention with a sham treatment or with a placebo which is not effective as a drug. But here we have two groups which are not placebo and intervention. We have an intervention, let's say a novel intervention with a traditional intervention. And we call it a placebo group, but it's not actually a placebo group, I think. And the title of the study is not correctly addressing a placebo-controlled study. Do you believe so, Professor Sabati?
You know what, Dr. Asadian, in the control group, they gave amoxicillin, and also we gave a pill, a color pill, resemble antiviral, and to the patient. Therefore, that was our placebo group. In other words, yes, in both groups you have amoxicillin, but we're testing the antiviral, okay? First group has antiviral. The second group had the empty pill, color empty pill, which is without taste, patient doesn't recognize it, as placebo. Yeah.
So I think, Dr. Sabati, the question is about when we have amoxicillin in both groups, obviously it means that we have a constant use of placebo in one group and also valacyclovir another one. But because both groups, they receive amoxicillin, it may have some effect as well. But on the other hand, Dr. Asadian, I personally think that when we give the patient both medications at the same time, so they both groups, they receive amoxicillin, as well as they both receive a lot of other things as well at the same time. So in that situation, I think they reduce their effect in both groups. Am I right, Dr. Sabati?
You're right, because we're trying to test the effect of antiviral. We should have amoxicillin in both groups. Otherwise, how we know that? Then it's going to be very biased, lots of confounding variables which cannot control. I think this is very straightforward, which is we want to have amoxicillin in both groups because we're testing on one group the effect of antiviral. We already know the amoxicillin. And then
we want actually to test that as an adjunctive, not as a sole medication.
Yeah, exactly.
No, as I said, this is a vicious cycle. You know, in order to viral get there, we need bacteria, we need immune system activation, which is caused by bacteria. That's why we need both together. Yeah.
And what about the exclusion criteria? Because in your exclusion criteria, we haven't seen anything about liver or kidney. And we know that valacyclovir is very, very somehow toxic for liver and kidney. What do you think about that? It was many of our colleagues, they were concerned about the safety of valacyclovir in this situation.
You know what? That's why we had it on the inclusion criteria, healthy patient, ASV or ASH.
Mm-hmm. All right. I mean, do you recommend it for us as a routine use? Because Professor Batul asked you the same question, that can we prescribe that? And you say yes. And if we want to prescribe it, do we need actually to check BUN, creatinine, urea for kidney, or SGPT, SGOT for liver function or not?
Okay, Dr. Nikufar, you know, if the patient has some issues like this, even ibuprofen is contraindicated in some cases. Even antibiotic is contraindicated. The same thing, you know.
So you
if the
think
patient
you're
has
not worried about that?
active kidney disease, active liver disease, absolutely have consult with a physician. But in healthy patient, no. But of course, lots of water, lots of drinking water. The same thing for the other medications.
And what about the ethical approval? Was there any problem for the ethical approval for the use of valacyclovir or not?
No, we had the IRB. You know, I think antiviral is not. I think it's a very safe drug compared to even some of the antibiotic. You know what?
Mm-hmm.
If any of you look at the ibuprofen, right? Even the one which you have here, go read the side effect of ibuprofen. You're scared to even take it.
Yes.
Right? I mean.
Yes.
Yeah, that's what it is. But drug is
okay.
drug. Yeah.
Okay, Dr. Kiafar, carry on. Thank you very much, Professor Severity.
Sure.
Is there any other question, guys?
Yes,
Nothing?
please. Can I ask you another question?
Yes, please.
Why did you exclude smokers, poor smokers? Is there any effect of smoking on pathogenicity of periapical disease or so?
No, it's a very good question.
Of course, I'm not a smoker. But
you know, we said more than 10, because in Perio, if someone smoke more than 10 cigarettes per day, we call it smoker, which has some effect on the immune system and circulation, suppose like this. That's why we excluded. It's less than 10 is okay, but more than 10. We want to make sure that we don't have any co-founder in this study. Everything be, that's
exactly.
it.
Okay.
Go on.
Dr. Kiafar, please.
Okay. Case selection, we have 21 patients screened for the study eligibility criteria. 1 patient excluded because of recent antibiotic usage. 20 patients were involved in the study. 11 female and 9 males. Age ranges between 19 and 86 years. And 19 necrotic and 1 previously treated case, which means it was a necrotic, but the treatment was initiated by another clinician. And the average length of the radiographic longest and shortest abscess diagonals was in valacyclovir group. It was from 6 millimeters to 4.7 millimeters, and in placebo groups it was 4.6 to 4 millimeters, which means it was worst. We have worst situation in valacyclovir group. Patient signed an informed consent. No mechanical endodontic treatment or abscess incision were performed at the time of entering the study, and patients were free to discontinue the study anytime for any or no reason. A study participant who wished to discontinue the study received expeditiously emergency root canal treatment, and all patients received conventional root canal therapy at the end of the study. Go to the next slide. For group assignment, we use a random number generator to make for 2 groups. We used APEC packets, which include medication and written instruction of the medications. We have two groups, valacyclovir groups and placebo groups. In both groups, we had amoxicillin, which was prescribed 1 gram immediately, and then followed by 500 milligrams 4 times daily for 7 days. And in valacyclovir groups, we had 2 gram immediate dose followed by 500 milligram 2 times daily for totally 3 days, which means from the day 4 and goes on, we don't have any valacyclovir in both groups. And the day 0 or baseline, the day 0 was the baseline because we have 7 days follow, and it's from the 0 to 6. I say it because in the schedule we have 0 to 6. For pain scale and analgesic intake, we have pain level range from 0 to 10. The potential candidates for the study was pain level 4 or more than that. Patients were educated and calibrated on numerical rating scale of pain during the initial visit, and a research assistant blinded to the study protocol phoned the patient daily to assess the pain level by NRS and for their analgesic usage. The NRS is a one-dimensional scale that is quick and easy to understand by the patient, and allow for both verbal and written administration, and is highly correlated with other pain scales such as VAS, as you can see in the picture. In the result parts,
sorry, Dr. Kiafar, can you please unshare, because there's a question from Professor Severity so far. Professor Severity, when we look at the protocol for the treatment of acute apical abscess, we cannot just prescribe some medication. We need to do some sort of root canal treatment, open drainage, or something like that. At least we need to do cleaning and shaping and get rid of some bacteria and the source, an antigenic source from the root canal system. How do you convince the ethical group to run such a study without doing any cleaning and shaping, any open drainage or anything like that? You just prescribe the medication for a week or something.
You know what? That's why it took us more than 3 years to have. Otherwise, we should finish it. Absolutely, you're right. But sometimes, patients come with the swelling and pain, acute apical abscess, doesn't have time, doesn't have financial resources, and or any other reason, and we don't have any choice except include the patient in the study. And of course, it's very hard to find those patients. That's why it took us more than 3 years. But we didn't want to do any IND. We didn't want to do any initial treatment because we don't want to have all of those co-founders in our study to say that, yes, this is this. Right now, which we have this, data, baseline data, absolutely I recommend if the patient, if you can, you have to do IND, you have to open it up. It's going to help. All is going to help, okay? And of course, currently we're doing a study on the antiviral to include all this, which is right now much easier to find the patient. But that's correct, Dr. Sefa. Yeah.
So it is not your recommendation just to prescribe the medication. Your recommendation is to have it as an adjunctive. So we can have antiviral, antibiotic after doing the cleaning and shaping.
Absolutely. No,
okay.
Absolutely. Of course, I don't say that. I don't recommend if the patient comes and he can do the treatment, do not do the treatment and prescribe antiviral. But if you have a patient for whatever reason, he cannot do or on the phone and has an abscess, this is a prescription you should do. Yeah.
Okay, Professor Abulsad, please.
I have two quick questions. The first one, since you mentioned in the inclusion criteria, it has an X-ray finding. So it is an acute extirpation of chronic infection, you mean, not acute from the beginning. This is my first question. My second one, why did you exclude marginal periodontitis patient? Why you didn't include periodontitis patient, since periodontal pocket can be a reservoir for viral infection as well? So how can you clarify that, please?
Sure. You know what? The terminology, whatever it is called it exacerbation. When the patient came to our clinic, we took the radiograph and saw the preapical radiolucency, we saw the swelling, pain, and all these things, okay? And we didn't do, or we haven't done any treatment on the patient, okay? Therefore, it's called acute apical abscess. And then as far as the marginal periodontitis, we excluded for an obvious reason, because if we include it, then someone may come and tell us, you know what, that has been perio, not endo. Therefore, we want to make sure that there is not any type of, pocket, which is basically the undermine the study and confused with the periodontal disease or periodontal abscess, because periodontal abscess also can mimic this, right? That's why we exclude it.
Okay, thank you very much. Professor Nair, do you want to add anything or?
Oh, no, it is quite clear.
Okay, that's fine. About the abscess, the question that Professor Nair asked, so can we call it phonics abscess or recurrent abscess for your cases?
You know what, we can, but as you know, right now, AAE doesn't have such a terminology. We followed AAE terminology. Yeah, I understand exactly, yeah.
But so Professor Nair description is correct. That means because they already have a chronic abscess that becomes actually an acute abscess, we can call it such a thing as we used to call it.
Yeah, in case if there has been a chronic, which is, we didn't know there, but if there is a chronic, for example, and become active, then we used to call it exacerbation of the chronic apical periodontitis. We don't have, AAE eliminated all this terminology.
Okay, and what about the measurement? Because in some of your cases, you use CBCT for the measurement. In some of them, you use PA. So can we call it as a co-funding variable or something?
No, you know what? We didn't have access to CBCT in most of the cases, because when the patient came to emergency, we don't take immediately CBCT, because it has to schedule the patient, come back the day after, just whatever we had. Yeah.
Okay. So that can be a source of the discrepancy between the groups or not?
No, because we randomize it. We didn't select, okay, put this one there, put this one there. Whatever we had, we just, randomize it blindly, and that's what it is. We report what we have.
Okay. Professor Faziab, do you have any question? Professor Zagar? Yes, please, Professor Faziab, please go ahead.
I first need to say hi to all of my colleagues, especially Professor Sabeti. آقای دکتر سلام، من طاقت ندارم یه ذره فارسی هم بهتون بگم سلام.
خیلی خوش آمدید، چقدر خوشحالم فارسی هم.
But not now, Mahta. After we finish it. We have a lot of audience from around the world. We cannot do that.
I understand. You can translate it, Dr. Nakufa.
Later.
I'm sorry to non-Persian audiences. We had to turn to channel 2 for special greetings in Persian.
Come on, go ahead, Mahta. We don't have time.
Okay. My question is that, Professor Sabeti, would you recommend this regimen for all of your patients who come across with such abscess and pain? My great concern was the safety of prescribing the acyclovir family members for all patients. As you may know, they may have some problems with the elevated blood keratin, or even they may change their serum results of the hepatic enzymes. Would you recommend that for all patients? And how did you just assist the patients for being healthy in terms of kidney problems and also hepatic problems?
Yeah, that's of course is a great concern, and this concern also is, even for prescribing antibiotic or Tylenol or so, you should have the same concern. Therefore, we just do a detailed review of the medical history based on what the patient tells you that. And if there's a patient is systemically healthy, that's perfectly fine. But if you feel that, or the patient tells you that, yeah, I have kidney issue or this issue, then of course you have to consult with your physician. Not only for antiviral, for anything, you should do that, because some other drug also can do the same thing.
But the first question was about, do you recommend it as a routine prescription?
This is very important. I recommend it as a routine prescription in healthy systemically patient who have acute apical abscess, not, for example, irreversible pulpitis, because we have not done that study. I know that the viruses have been detected in that irreversible pulpitis, which, by the way, I don't like the terminology of irreversible pulpitis. However, this is, yes, for acute apical abscess, I recommend it, and also we just prescribe it here. Yeah.
Okay, Professor Zager.
Thank you.
Thank you, Atta.
Hi, everybody. Thank you, Professor Nekufar. Warm greetings to my professor, Professor Sabeti. I missed you.
We all.
I want to ask about this drug in the pandemic of Corona. We know that Corona patients should use antiviral drugs. And when you use this drug, they lose their reserve. And because of some problems in their liver and kidney, maybe they can't use their drug for Corona.
I think because, Professor Sabati, in your article, you also recommend that during the pandemic, we may prescribe it by telephone. And Professor Zager is worried about the use of that in a patient that may suffer from COVID-19 infection, because they already have under a lot of medication that may have some side effect on kidney and liver.
With that, by the way, I say hi to Dr. Zager. It's good to see you, Dr. Zager. Yes, of course, this is part of our diagnosis and medical review at the beginning, right? All of us first do a true examination, are subjective and objective, and part of that subjective or objective is medical, right? Review. And of course, if we feel that patient has had such a thing or so, of course we have to be cautious. And this is of course we have to do that. We have to review the medical history. Is very important. And one of the reasons for this is this one: if they feel that we cannot give it to the patient, do not give it. Yeah.
Okay, thank you very much. And one of our very good colleague, actually, who kindly accepted our invitation before you, Professor Sabati, is Professor Alexander, and he is one of your fan as well. Alexander, do you add something?
Yes.
Hello. Hope that
Hello,
you
Alex.
hear me. Hello.
Yes, very well, very well. Thank you very much for joining.
Oh, it's my pleasure. It's always my pleasure. Dear, first of all, I would like to send a warm greetings for all participants, and to Professor Nekufar to send me an invitation, and of course to one of my biggest fan in Endo, Professor Mike Severity. I actually I actually believe that I forwarded his way in science because his basic innovations in pathogenesis of apical periodontitis led us to learn and to explore more about herpes viruses in etiopathogenesis of apical periodontitis. This is a great paper. I already said, Professor Nekufar, that I saw and read it as soon as it was pre-proof online at the Journal of Endodontic website, and unfortunately, due to my due to my very busy schedule, I didn't have time to send an email to Professor Severity to support and to congratulate to him. So I actually use this opportunity, and Professor Severity, this is one, how to say, a pioneer, another pioneer work in your big career, very big and important career for all scientists in the world. What I would like to add, Professor Severity is fighting almost 30 years to put in head of endodontists that viruses are almost almost same important as bacteria and other microorganisms in pathogenesis of apical periodontitis. So it is really important to learn something from periodontology, from their very big and important science to endo, because it was only one case report that was reported previously related to the application of antiviral drugs, and it was a case of very severe periodontitis by Sande and his colleagues from Norway, from Oslo. And this is really important paper because I actually agree with some concerns presented by other participants, but also I strongly support Professor Severity because I know it was very hard to randomize and to make clear groups, to make there is a lot of ethical consideration in our clinical studies. We cannot just induce apical periodontitis and start with some medication to see what will happen in the future. So someone was asking Professor Severity about smoking and the period status of the participants. It is also important that people who are in endo realize that smoking and periodontitis are co-founding factors of apical periodontitis. So it needs to be eliminated in any possible way. Another very important question is prescribing the antiviral drugs. Antiviral drugs is as any other drugs with all limitations. We just need to be very careful. That's why we have medical knowledge in dentistry. We have pharmacology, clinical pharmacology. We have to learn all these issues. And the most important thing is that we have to be aware that viruses, especially herpes viruses, are very present, and they, in combination with bacteria, can do very bad things to the bone resorption at the periapical area. Another question that was raised by other participant was, should we use randomly antiviral drugs in any case of acute abscess? Professor said that he personally recommended that. I can support his opinion. He's more experienced than I, but maybe in this area of fast PCR testing, because these viruses are in a few hours, you can have the result of PCR testing of any viral antigen in human body. Maybe after we open that, after providing drainage and do some clinical therapy, to use to take a sample of the tissue, and after the sampling of the presence of potential harmful viruses, after the testing to include antiviral therapy. As you are probably aware, previous studies were not so perfect because of the prevalence of herpes viruses in periapical ptosis, because some of them have a small sample size, some of them were not, how to say that, well performed in methodological perspective regarding the PCR testing. But probably, as we know, all these issues right now that are published in our two latest joint publication between our group and Professor Severity, we put some recommendation for the future. And I strongly support and believe that this is another pioneer work of our dear and great Professor Severity. So I'm so thankful to him for all the knowledge that I get through the papers and through the correspondence. And I actually, this is the first time that I actually saw him and hear him, and it was really my pleasure to participate tonight. Those are my opinions, and thank you once again.
Thank you very much, Alex. Thanks for joining and your comments. Professor Severity.
Sure.
So this is
Dr.
Professor
Alexander,
Sabati, Alex. This is Professor
you know,
Sabati.
I really love his work. I basically, as a matter of fact, I have a couple of his papers right now by me. He's great. He knows what he's doing. I really enjoy his work, and I admire him for his persistence in this field, and I really enjoy. I really love to work with him. For your information, Alexander, Professor, we're just having a couple of IRBs right now and performing 2 major clinical trials and looking at different things. Hopefully, it's going to take time, but hopefully, have some more information. And also, we are writing $2 million grant. Hopefully, finish it by February in this area. We're working hard on this one, and absolutely, I'm there. If there is any idea or any basically help, I just please contact me. And as I said, I enjoy your team. You have a great team, great work. Or so. By the way, also I want to mention that after this article published, there is a group in the United States which is they say that this is one of the best in the past 100 years, which is happened to endodontic. Of course, they believe that they are not endodontists, they are periodontists and microbiologists. They believe that endodontics is behind in realizing this. It may take 20 years from now to fully understand the situation. But anyway, thank you so much for your comments and your idea and your thought about this topic. Thanks.
Thank you very much.
Dear Professor Nekofar, may I add just something?
Yes, please go ahead.
Professor Sabati, the pleasure was all mine. I'm always saying that your work was pioneer work for etiopathogenesis of apical periodontitis. And I'm kindly asking all persons that are attending our meeting tonight to read all papers written by Professor Sabati, because we need to learn that herpes viruses are very important microbes that could lead to destruction of apical periodontitis. And this synergy with bacteria is important that people are aware of that. There is a lot of people who doesn't really think that viruses in combination with bacteria could manage such resorption in the periapical area. Those are things that are on molecular level, but it's important to share knowledge with our colleagues to know that. So that's the point. And for the grant, Professor Mike, if you have some postdoc, I will attend it, of course.
My pleasure, Dr. Alexander. I will communicate with you.
Thank you so much. Thank you.
Sure.
Okay, thank you very much. Maliha, we are waiting for you. Okay, Dr. Keffer, we're waiting for you.
So in the result part, we have 2 tables. the first one, it's about the pain of the patient with acute apical abscess. We have two groups, valacyclovir groups and placebo groups. In each groups, we have two columns. First one is patient with pain with level 4 or less than it. Which means even 4 level is inside this group. And the second one is
You carry on, please. You carry on. We will find the source of
the
the
second one is the patient with no pain. So in the first day, in the baseline day, all the patient had in the valacyclovir group had pain more than 4 level, and in placebo groups we have one patient with 4 levels pain, moderate pain, and the others had more than that. After starting the medication from here, in this first day, 80% of the valacyclovir groups had pains 4 or less than that, which 20% of this patient had no pain. This 20, which is here, it's a part of this 80% in the first column. And when the medications goes on, it's 100% of the patient in the day 3, which the valacyclovir therapy is ended there, had less than 4 levels of pain. And from this day and to the end of the study, only the patient with no pains increased in this group. And the percent of the patient with no pain was about half of the placebo group. It's 60%, and here it's 30%. And in other cases, it's the same, 40%, 20%, and 20%, 10%, and like that. But in the placebo groups, we didn't have this effect. And the difference in the pain relief in the valacyclovir group and placebo group was statistically significant for each post-baseline day, except for day 4. May I go to the next table, or you want to stay here? Next table?
No, that's fine. I think it's very clear. Is there any question? Anybody? I don't think so. You carry on. I think Professor Nazari Mogaddam has some question. QMARS, please go ahead. Professor Nazari Mogaddam, QMARS, please.
Hello to everyone, and hello to dear Professor Sabati. It's my pleasure to see you. I am always your student and learned about you. And I think this concept is so we have many ambiguous. I think the first step is which is the early comer in the preapical region. It means first bacteria inside the canals attract inflammatory cells that carry on herpes virus. Is it right or not? And also, I have a question. Do you think, as you know, in the pathogenesis of the sinus tract and the big lesion and the periapical abscess, certainly herpes virus involved. Do you think that local usage of the valacyclovir or acyclovir inside the colon can be effective into resolving exudating from the corners or big lesion, such as calcium hydroxide therapy? Thank you very much.
Professor Sabati, please.
Sure. Professor Nazari Mogaddam, hi, how are you, sir? It's great to hear your voice. You know what, start from your last question, it may, but I don't have any data to tell you that. We need to, or someone need to basically perform that study to have an objective answer. But based on my idea, it may work, but I don't know really till we do the study. However, as far as your first question, yes, you know, when we need the bacteria, absolutely, because as soon as for example, LPS get to the preapical area, and then the innate immune system basically start the process of defending, which is inflammation. Then the cells come, and through those cells, the viruses come to that area, and then the thing start, the cycle start. Yeah.
Okay.
Thank you very much.
Okay, Dr. Kiafar, please.
In the next table, we have analgesic consumption of two groups. We have three columns here. First, the patient with would take no analgesic. The second one, patient with on NSAID or acetaminophen therapy, and the second one, narcotic or gabapentin. In the first day or the baseline day, all the patients, almost all the patient was taking some medication. Only one patient in both group did not use analgesic, the 10%, and the others, 90% here, 90% here, took analgesic in the first day. Just here in the valacyclovir group, one patient took narcotic or gabapentin instead of NSAID. But in the first day or after the baseline, after the medication, 90% of the valacyclovir groups did not take any medication more, and only one patient had NSAID, and this patient kept using it until day 5. And in placebo groups, we didn't have such result. In the first day, we didn't change any thing, and all the patient which was using NSAID kept using it. And in the day 2 or more, it's only reduce the pain gradually and step by step, not that fast we had in the valacyclovir group. And even here in the day 6, one patient had more pain. It changed the medication from NSAID to narcotic. And the difference in analgesic usage between the valacyclovir group and placebo group was statistically significant in each day. Any question?
Is there any question? No, carry on, please.
And there was no significant difference between males and females in pain level and analgesic usage during this 6-day study. In the discussion, we can look at the result.
Do you want to add anything before we go to the discussion part, to the last part? Is there anything that you want to add, Professor Severity?
No, sir. No, nothing.
Okay, thank you.
The result of the study, the result of the study agrees with our hypothesis. The potential of valacyclovir to suppress pain of acute apical abscesses shows us that a major pathogenic role of active herpes viruses in endodontic pathosis. And considering this, we can add valacyclovir to traditional root canal treatment to have a sooner pain relief or early pain relief after the treatment. And the rapid pain relief by valacyclovir treatment shows us maybe the main culprit of this pain was herpes viruses. And we can use for patients, as Dr. Severity mentioned, by phone or internet, that the patient who are not temporarily able to attend to dental office or take any root canal therapy, this valacyclovir treatment and reduce their pain. And we have something here, the association between herpes viruses and flare-up. Herpes viruses reactivate from the latency spontaneously or due to immunosuppression, infections, physical trauma, or hormonal changes. And probably this herpes virus activation factors may double the risk factor for preapical flare-ups. And there will be a relationship between flare-ups and herpes viruses. And as Dr. Severity mentioned, there is a cascade. Activated herpes viruses reach a critical virus load, and then the macrophages and lymphocyte and connective tissue cells, which was affected by this virus, start a cytokine and chemokine storm, including interleukin 1, TNF, interleukin 6, prostaglandin, and interferons, which cause an inflammation in enclosed area of preapical lesion and cause pain. And the placebo group outcomes raised doubts about does amoxicillin monotherapy effectively control the pain, because we didn't see any significant pain reduction in that group. So maybe it doesn't work. But in the continue, we have this sentence that most common antibiotic treatment by United States periodontitis is amoxicillin plus metronidazole or ceprofloxacin plus metronidazole, because they have synergistic interactions. But I have a question: why we didn't use this medication instead of amoxicillin alone when we know that it was the most common antibiotics?
Professor Severity, that is also a big question from other participants as well.
Yeah, that's, the use of the amoxicillin and metronidazole is mostly done by periodontists in the United States. Endodontists mostly use amoxicillin, and yes, some of them do, but since routinely they do amoxicillin, that's why we did the amoxicillin. Although metronidazole has some effect on gram negative, but we did not include it in the study. And one thing also I would like to mention that we reported the pain level, because that's what is important for endodontists, and what's the patients complain about mostly. When the patient does not have pain and a little bit swelling, most of the time even do not call. Oh yeah, but there's nothing. Pain is the main thing for the patient, and that's why we reported pain. Although the swelling also reduced dramatically in the test group. Okay, and also he mentioned about those gamma interferon, and which is very important. Like one of the structural component of the ABV is resembled to IL-10, which is what the IL-10 does, basically decrease the level of the gamma interferon, interleukin-2, and all the things, and then shift from Th1, which is more protective, than to Th2, which is more basically plasma cells and more destruction. And that's what we see. Anyway, and that's, of course, is all the pathogenesis of the herpes viruses. Yeah.
Thank you. And we have some suggestions for future research to determine the optimal length and dosage of valacyclovir. Maybe we don't need 3 days, or maybe we need more days for this valacyclovir treatment, and to determine the ability of valacyclovir alone or in combination with bacterial antibiotics to arrest or even reverse preapical bone destruction based on Sunday et al. Findings for periodontal treatment.
That's a good suggestion. We're currently doing it as part of the research we're doing right now.
Okay, thank you very much, Majid. Carry on, please, and finish it, because we are going to finish on time. I'm very happy.
In the inclusion, it's clear that severe preapical lesions contain both active herpes virus and bacterial pathogens. It's unrealistic to expect that mechanical therapy alone or antiseptic agents delivered through the root canal can neutralize infectious agents in difficult to reach preapical side or outside of the root canal. The recognition of microbial specificity in a severe apical periodontitis support the use of chemotherapeutic intervention by antibiotic-like agents. An important advantage of systemic antimicrobial therapy is the ability to reach endodontic pathogens, especially herpes viruses located in outlying area of preapical lesions. The possibility that a relatively simple chemotherapeutic intervention can arrest severe preapical disease and perhaps lessen or prevent systemic disease constitute a significant conceptual advancement in endodontics. And mRNA vaccines against HCMV and EBV are in various stages of development and can comprise a new interesting approach to the prevention of severe endodontic disease. And research on herpes viruses is still in its infancy and deserve considerable attention.
Thank you very much, Dr. Kiofer. Thanks a lot. So, Professor Severity, usually at this stage, we ask the author and other colleagues to give a mark to our graduate resident. And I should say that Dr. Kiofer did a great job. He presents your article with a lot of confidence. Sometimes even he said, we did that. And I was very proud that he thinks that he did it rather than you did it. By the way, that I'm very proud of you, Dr. Kiofer. Thank you very much. And you did a great job. And I'm asking Dr. Severity to give your mark. Dr. Severity, what do you think? Do we give him A+ or B or C or D or whatever?
I gave him A+. He did
okay, thank
job.
you very much, Dr. Kiofer. Thanks a lot. You did a very good job, fantastic. I'm very happy. Actually, when we start this work, I was very worried, to be honest, about the possibility for having such a fantastic discussion. By the way, before we go to the last part, I want actually to say some good things about our beloved Professor Kazem Ashafte Yazdi, who already published an article with Professor Severity about the viral infection. I leave it to you, Professor Severity, to speak about him.
Yeah, it's so sad not having him with us. You know, he was a great person. I had lots of, talk with him when I was, there or coming there. He was a great man. He has a great heart. He just cared about, people, and he was so ethical. I mean, he was so ethical. I mean, you know better than me, Dr. Nekufar, how great person he was, and I really enjoyed him.
Yeah,
and,
we all missed him.
God
So
bless
it's good
his soul.
time for all of us to recite Fatah for him, and we hope actually his soul will be in peace. And I'm sure he is, because he trained a lot of students around the world, and we are very happy to have such a professor in our department. And he always told us to support your studies, and he was actually a very close friend of you. I will remember that. Okay, and another things that maybe in the future we are going to have such a things is some of our colleagues, they send us some images from their patient that they have problem in terms of diagnosis, and they ask us actually to discuss those cases with something like in a group or something, to say what should he do about that case. So there is actually a case of a 9-year-old a female patient. Let me check to make sure that I'm going to read the history of that case correctly. All right. Yes, she's 9 years old, and just they decide actually to do orthodontic treatment for this young kid, and they actually couldn't see all the roots. Let me find the radiographs and share the radiographs with you. Just give me a minute, because the father of this patient, actually, he's an endodontist. He sent it to me and asked me to share it with others and to suggest some sort of treatment for her daughter. I'm trying to find the radiographs. Sorry, keep you waiting for the, oh yes, that's here. Okay. So this is the radiograph. Can you see the radiograph? Can you see the radiograph, Professor Severity and others?
It's not diagnostic, Dr. Nekufar. I don't.
Yeah, I know the quality that they send it to us is not very good as well. I will actually ask them to send a good one. As you can see, we have a resorption in this case without any reason. There isn't any systemic problem. As you can see in the molar area, in the premolar area, in the central area, they have the patient, and she is just 9 years old. And they just find it because they just took this radiograph for the orthodontic treatment. If our colleagues, they have any idea that can help our endodontist colleague for his daughter, maybe it's a good idea to share it with me in the future. I will share it with you in our groups.
Excuse me, Professor
Hadi
Nakufa,
and Mahta wants to talk. Please, Mahta and Hadi. Go ahead, Hadi.
Excuse me, according to the patient's age, I think she has to be in her mixed dentition stage, and we have to see some milk teeth, deciduous teeth, but the deciduous teeth are not present in the radiograph. I think there is a problem with the systemic issue. I think
there wasn't any systemic issue according
Dr.
to his
Nakufa,
father.
Dr. Nakufa, have they done genetic test?
Yeah, genetic test, not really. Let me check. So what is your question about genetic test?
No, just because, I just follow up what the doctor said. I agree. At least we know whether there is a genetic things or not. But just, I'm sorry for interruption. Continue.
No. What they said, actually, what it sent it to me is about all the tests in terms of alkaline phosphatase, parathormone, all the hormones and everything is normal. Nothing about that. There is a deviation in the occlusion of the patient, just that. And then they just, and then the age, as I said, is 9 years old.
That's exactly, the line of the basically.
Sorry, 12 years old, 12, not 9, 12. So that is the answer to Hadi. She's 12.
Yeah, Dr. Hadi can continue. Yeah.
Can I ask you something? You said that the serologic tests were normal for alkaline phosphatase and parathormone tests.
Yes.
They may be a problem. They may be a problem with rank-RANKL system. I don't know what are the specific tests for that one, but I would recommend taking a CBCT. There may be some abnormality with the bone.
Mm-hmm. And what about the treatment? Is there any suggestion for the treatment?
I think we need to find the etiology first. That's the most important thing, and after that we would find a good treatment for this one. I would recommend also consultation with an orthodontist. There may be some syndromes that just I have nothing fresh in my mind to just name them. But
again, I think that even if the patient is 12 years old, I think that the chronological age is not corresponding with the dental age. I think the patient is currently suffering a sort of progeria. I mean, she's getting older than she is. I think this has some genetic problems. This can be attributable to genetic problems, of course. And of course, the case is a systemic case, and we have to look it for, I mean, it has to be, I mean, it's consultation with even an orthopedic surgeon is also necessary, because I think the bone metabolism can be deviated. I think it's not normal according to the patient's age. The chronology is not corresponding with the dental age.
Dr. Nakufa, does the patient has a speech delay?
No, she is normal. She is normal. As far as his father told me and said,
no speech delay. Never had a speech delay.
Nothing.
I think before doing anything else, a genetic test is required to see whether
so consultation with some genetician.
And also I think the first line, and then we can follow after that. If there is, then there is. We know what's it. If there is not, then follow up with others.
Okay, and
to find out the etiology.
For the treatment, we don't recommend any type of.
Dr. Parker,
please, matter.
I think there must be something just because as you see, all the problems are just in the right side of the face.
Exactly.
The left side, and that is something very important.
You're absolutely right. That was the first things that I told to his father. And then they understand that the condyle on one side grow more than the other side. And the deviation is because of the overgrowth of condyle. They say that the right condyle has, the neck of the condyle has 2 or 3 millimeter larger growth comparing to the left one. That is what his father sent it to me.
And the maxillary sinuses do not seem normal. I again would recommend taking a CBCT.
Okay.
Just for evaluating the bone.
Okay, thank you very much. So that can...
Professor,
yes, please.
Do you know that there is an imbalance between rankle and osteoprotein? Is the presumed that's involved in this case? And I think when we have imbalance, it's impossible to do orthodontic treatment because it promotes root resorption. And
Yes.
also, as you know, CBCT is prohibited for the age under the 15 because the absorption of the radiation is 2.5 than the adult person. So I think it's better to analyze different index by different consultation. Also is orthopedic and orthodontic consultation we need in this case.
Okay, thank you very much indeed. And I just want to use this opportunity to maybe introduce a new program in the future that we can arrange such a things, prepare the cases very well by all the information that we need in terms of laboratory results, good and diagnostic imaging, good history of the patient, and then we prepare maybe something like monthly discussion on this subject in the future. Okay, now it's time to say huge thanks and huge appreciation to Professor Severity. Professor Severity, we are very proud of you, very proud of you. And we are very happy to have such an Iranian fellow in the state that can have our flag everywhere in the world. Thank you very much, Professor Severity. We put our hand for you and thanks for your publication.
Thank you,
and all of your effort. Thank you very much.
Thank you so much for your kind word. And I really want to appreciate everyone for participating in this case, I think, study, whatever it's called, which is great. I think to me is great. Very, we can get a lots of things out of these discussions. Thank you so much, everyone, my colleagues, my friends, and I wish you all the best. Dr. Nikufar has my email if anyone wants to communicate with me or something or so. By the way, I want to say one word to my colleagues, or to endodontics and periodontal colleagues. The latest FDA report, which came out, indicate that no medical device has had more problems so far in the history of FDA except implant. This is a discussion. This is a discussion we had yesterday between a group, very, very prestigious group in the United States, including Dr. Slotz, which is this report is on FDA. I can send the share. Therefore, I suggest we save our teeth, as always suggested, save the teeth by endodontists and periodontists, because implant has more problem than we expected. Okay, it has its own place, but has right now, based on this report, which is the most problem with medical device, that's amazing, blowing your mind how this happened. Anyway, thank you so much. Have a great evening, great night, and stay safe.
Okay, thank you very much. Any comment from anybody? We are open now.
Excuse me.
Okay. Yes, please.
According to the suggestions that we usually have at the end of the at the end of each article, I would like to raise this flag of having joint collaborations between Iranian universities and Professor Severity to have more fundamental studies. I think it's necessary to have more fundamental studies in terms of, for example, signaling pathways of affecting viral particles. I mean, the influential issues about viral particles in apical periodontitis. And because the signaling pathways are now gaining much more popularity than before, I think it's really good to have this line of research. And I think that it's good to have a joint collaboration between us and Professor Sabati to have this joint activity. And for example, about osteoclastogenesis, about signaling pathways, about the influence of viral particles in bone resorption. And of course, it's nice to have cohort studies. We have a large number of patients coming to our clinics, to our universities, that we can have these antiviral therapies in terms of cohort studies with large sample sizes, and we can provide strong evidence of this. I think it can be good to discuss in this topic. I think what's your opinion?
Okay, thank you very much, Hadi, for your session, and we will be in touch with Professor Sabati. Professor Sabati, have a very good weekend and hope to see you soon. Before we say goodbye to everybody, I'm going to ask Maliha to show us the last video of our sponsor. Thank you very much. Okay, Professor Sabati, last word by you, and then we say goodbye.
Well, you know, as I said, I really enjoyed. I didn't know the level of this, you know, monthly, I guess, right? It's monthly.
Yes, yes.
It is wonderful. It's great. And appreciate Dr. Nikufar, you and whoever behind this, arranging this kind of things. It's so beneficial to all of us, including me. I really love to join for the next session, whatever it is. I really enjoyed it. And then thanks everyone. I know sometimes it's hard, you know, come and join for whatever reason. I really appreciate, and I'm hopeful I did not waste anyone's time. And then we all learn from that. And have a great evening. And you know, looking forward to work with all of you. I mean, that should be great. I think, as Dr. Astadian suggests, as Professor Alexander suggests, I think I'm open to it, and we should do that. We should do that.
Okay, thank you very much, Dr. Sabati, and goodbye, everybody. Bye-bye.
Thank you. Bye-bye. Goodbye.